Hi, David Liew here again, talking to you a little bit today about PMR and JAK inhibitors. I hear a lot said about, well, there's potential for JAK inhibitors to help in PMR, but what about the data from oral surveillance and the concerns there? And really, let's wipe that off the table. And it's been a really interesting conversation because I think there's an increasing realization, especially now that we've got a registered medicine for polymyalgia rheumatica in the form of sarilumab. There's been a really interesting conversation about glucocorticoid side effects in polymyalgia rheumatica, the burden of persistent disease in polymyalgia rheumatica, the fact that we have over half of patients having over a year of disease, over a third of patients having over 2 years of disease. We've got this massive burden of polymyalgia rheumatica that's really been unaddressed. And it is one of the diseases, and especially as far as common disease is concerned, it really stands out as something which we've left unsolved. So what we saw at this meeting was some data on polymyalgia rheumatica and JAK inhibitors. But I just want to give you a bit of a schema first in terms of where polymyalgia rheumatica therapy sits, because we often think about refractory disease, and I guess that's what we think about in rheumatoid arthritis. We think about moderate to severe disease. That's similar to refractory PMR. I've also got newly diagnosed PMR as well. So thinking about starting a steroid-sparing agent, or DMARD, at the very beginning of therapy when we're first starting steroids. So they're two different paradigms, and there's different challenges with both. I guess if we think a lot about the refractory paradigm, which is where sarilumab is registered in, and JAK inhibitors make a bit of sense there because they're hitting all the relevant cytokines, and in particular, they're hitting the cytokines relevant to interferon, well, to the Th1 pathway in GCA, and that potentially we might be stopping the risk of future GCA there in those refractory patients. And we know that JAK inhibitors have had success in GCA in the SELECT GCA study, which was presented at this meeting as well. So that is certainly something to think about, but that also probably does involve more persistent use of JAK inhibitors. Whereas actually, in newly diagnosed PMR, there are some certain advantages to JAK inhibitors, which might be of real relevance. And that's where the BACHELOR study came in. So the BACHELOR study was presented at this meeting, abstract 0858, from French colleagues, from Valérie de Chevel-Pensec and her colleagues in Brest, looking at baricitinib in newly diagnosed PMR. So starting at the same time as glucocorticoids, starting baricitinib then, first at a slightly higher dose, and then gradually tapering down. And what they found, in fact, was that in that first 12 weeks versus placebo, they found that actually baricitinib was able to deliver a 77% response rate versus a 13% response rate for placebo. In fact, it's surprising that placebo was even that high. And really, I think there's a lot of encouragement there because this is a new therapy in an area where we don't actually have any proven therapies, newly diagnosed polymyalgia rheumatica. This is obviously not phase 3 level data, but it gives us a lot of encouragement. I think there's a lot of reasons why we could get excited about JAK inhibitors in newly diagnosed PMR. Firstly, they've got a relatively rapid onset. They're able to be titrated as well. The daily dosing or twice daily dosing in case of tofacitinib means that we can titrate up and down. And so, in fact, in the BACHELOR study, they looked at titrating down from 4 milligrams up to 12 weeks down to 2 milligrams after that. And that's certainly a very valid strategy that you could imagine rolling out with upadacitinib or tofacitinib. And really the key as well is that we're talking about an early, short, sharp burst at the beginning of PMR to try and prevent future damage. So really the safety risk is limited because we know that with JAK inhibitors, cardiovascular and cancer risk does appear to be related to exposure when we're looking at TNF versus TNF inhibitors in rheumatoid arthritis. So when we're talking about this context, we're talking about maybe 12 weeks, maybe 24 weeks of JAK inhibitor at the beginning of a polymyalgia rheumatica patient's therapeutic course. That's really quite limited risk. And of course, then the final kicker is that tofacitinib is coming off patent or has come off patent in most of the world. And that really means that generic tofacitinib, to be cheap to produce, could really open this up and get down to a cost which maybe, while not competitive with prednisolone, is certainly in the rough ballpark. And that's a key factor here for a common disease that affects a lot of people. So for plenty more on JAK inhibitors and actually plenty more on polymyalgia rheumatica, you know where to go, rheumnow.com.